Welcome, everyone. My name is Madeline No, and I'm with NetHope. Thank you for joining us for another NetHope Solution Center webinar. Today, our topic is digital tech to support the global malaria response. And today we're welcoming presenters from Population Services International, Catholic Relief Services, and PATH. Before we get started today, I'd like to go over a few of our housekeeping guidelines for the session. Please keep the session interactive. Please post your questions and your comments in the Zoom chat window, and we will have a Q&A session toward the end of the hour using all of your comments and questions. And also look for a follow-up email today with a link to the recording for the session that will include a link to the collateral or any other information that comes out of the session today. And toward the end of the hour, we'll post a link to a webinar satisfaction poll. Your feedback is very important to us, so we would encourage you to take a couple of minutes to complete that satisfaction poll. And with that, I will turn it over to Sonia Rutzel from CRS to kick off our presentation today.
Thank you very much, Madeline, and thank you very much, NetHope, for hosting another ICT4D webinar with us. So today we're talking about digital technology applications for global malaria response. And we have a very fantastic speaker panel for you. Each will give you a short presentation, then followed by a discussion. So we will hear from Orezi Nicholas Adhikobiyibo. She's the Senior Manager for Vector Control at the Global Fund Malaria Project in Nigeria at Catholic Relief Services, and talk about different tools used by CRS for global malaria response. Marie Rain Rutag-Vera, she's the Strategic Information Advisor at PATH, and Marie Rain will give us some insights on malaria and COVID response and lessons learned from the past year. And we also have Luigi Nunez. He's the Digital Health and Monitoring Advisor for Malaria and WASH at Population Services International, PSI. So thank you very much for our speakers to share their insights. I'm very much looking forward to this session. For the attendees, as I said, we will have the individual presentations first. And please feel free to post any questions you might have for the speakers in the chat, as we are following with a discussion afterwards. And also, I like to highlight that the presentation slides will be shared with you after the session as well. So don't worry about being busy taking notes. So without further ado, I'd like to hand over to our first speaker, Orezi, giving an oversight on digital innovations for fighting malaria at CRS. Orezi, the platform is yours.
Thank you very much, Sonia. Hello, everyone. I'm happy to be here to make this presentation on the use of ICT4D in malaria control response. Can we go to slides, please? Good. So just to mention that the use of technology for malaria response has really helped greatly in achieving the universal coverage objectives for malaria interventions to align with WHO's Global Technical Strategy for Malaria, the 2016 to 2030 strategy. So basically, we'll be showing you examples from Nigeria and Benin on the CAT strategy using the Red Rose platform. And we'll be looking at triangulating malaria data using the iForm Builder and GIS mapping and ComCare as well to analyze prevalence, and we'll also be looking at the lessons learned from Sierra Leone and how various platforms have been used to support SMC and ITN mass campaigns in Gambia. Next, please. So basically, the CAT strategy helps to improve accountability and efficiency in program implementation, such as ITN mass campaigns. And this mainly involves the use of mobile phones, softwares, and associated peripherals, So you have things like the net cards, fingerprint scanners. And for ITM mass campaigns, the CAT strategy has really resulted in an increased access as well as use of the ITNs, especially in populations that are mostly at risk of malaria. Next, please. So looking at this slide, these are some of the CAD devices, tools, and peripherals that we use to support program implementation, such as the ITMS campaigns. So you can see the Samsung A5 phones, which is basically used for data collection at household level. You have the fingerprint scanners that we use for biometric time and attendance tracking during trainings. You can also see at the top right, we have unique badges with QR codes that we use to track. They are kind of unique to each participant during the trainings and implementation of activities. And you also have the vouchers who come with very secure holograms. So these are some of the tools, devices that we use to support program implementation using the CAT platform. Next, please. So basically, Nigeria had its first introduced technology for campaigns in 2017, and we had a pilot in Oyo State in 2017, though it was at a limited scale where we used technology for attendance tracking, biometric attendance tracking. And the first pilot, we used a total of 200 devices. However, we've scaled up to the use of 6,100 devices that are currently being used across the country from 2018 up to now. So those are the 6,100 devices that we use to support program implementation in the country. So if you look at the CAT strategy for ITNs and ITM mass campaigns and SSC campaigns during implementation of activities, what we get is data reporting is generated real time and can be accessed and viewed on the CAT platforms. So what happens is these processes and tools are modified into softwares and dashboards on the CAT platforms. And somehow we can now monitor the hours that are spent by each of the personnel during trainings, including impersonations, and trainings are now monitored using the biometric attendance tracking. So also, using the key markup whole language as the KML files, we kind of have a quality control of household mobilization and ITN distribution process during mass campaigns. And we also use geospatial data to track these processes, including mass drug administration for SMC campaigns as well. So one major issue that we usually encounter during the mass campaigns especially is the payment of personnel after work. So, but with the integration of the financial provider for campaign personnel bank account verification, what we do now is we can quickly verify account details of campaign personnel, and this process has greatly improved our payment processes. So payments are now timely, and we have now reduced the issues around payment of campaign personnel after work. So this CAT component basically shows you some of the processes that we use using the CAT strategy for implementing ITM mass campaigns in Nigeria. Next slide, please. So for 2020, that was last year, CRS digitized the LLI mass campaigns in 3 states, Adamawa, Kwara, and Osun State. So if you look at the heat map to my right, the colors on the red shows the distribution of ITNs across Adamawa State. So this is just a picture representation of for Adamawa State. So the heat map on the right with the red dot shows where the nets were actually placed. So at a glance, you can see where ITNs are located within the household in Adamawa State. So For this slide, I'll just be speaking specifically to Adamawa State. With the use of the technology, we're able to engage 8,800 personnel across the state, and we used 8,817 devices which were configured and were deployed for household mobilization and ITN distribution. Just to mention here that due to the COVID-19 last year, we actually did household mobilization and ITN distribution simultaneously. So meaning once we registered the households, they were issued nets. So we didn't have the two different processes. They happened at the same time. So that approach was done using the single phase door-to-door strategy. And with the use of the CAT platform, at the end of the campaigns, we were able to pay 99.83% of all campaign personnel that supported the mass campaign in Adamawa State, and our ITN distribution rate was at 99.8%. So this is just an example of the data that we can get and the information we can get using the CAT platform in 2020. Can we go to the next slide, please? So for Benin, CRS assisted the government of Benin to digitize their 2020 ITM mass campaigns as well, using the Red Rose technology in the context of COVID-19. And also CRS leveraged on the MAXA technology. So it allows for the aerial view of the targeted area on the map. So that's what you can see on the right side. So you can get an aerial view of the entire region. So the areas highlighted in green are the areas that were actually mobilized. And at a glance, you can see the missed households in red. And this supports you in planning for if you need to go back and re-register the households and issue them with ITNs. So the AXA Mansa technology actually ensures that no household is missed during the mass campaigns, during the activities, and it gives a better mobilization, distribution, and surveillance of the coverage. So CRS subsequently leveraged on the 2020 ITM mass campaign database to digitize the 2020 SMC campaigns, because this data was already existing on the CAT platform. So there was no need to have a new set of data. So that data was leveraged on, and this was used, the household mobilization and ITN distribution.
Orizi, we just lost you. Can you still hear us? Sorry, that's, I think you have some connectivity problems.
Can you hear me?
Now it's perfect. Thank you.
Okay, sorry about that. So do I need to, I should go ahead, right?
Yes, please do. Thank you. We probably just lost the last couple of sentences. Thank you.
Okay, yeah, so let me just go back to say that as for the 2020 campaigns, for the SMC campaigns, so because we already had data from the 2020 campaign, so CRS in Benin leveraged on that data that was already existing for SMC campaigns. So there was no need to go back to generate a new set of data, because that data was already existing. And the data from the household mobilization from ITN campaigns was used for the SMC campaigns. That way, there were some cost savings on the SMC side, because they didn't need to do a fresh data collection. This data was already existing on the CAT platform. Now, based on some of these successes for these two campaigns, so there are currently talks that are ongoing to digitize other campaigns outside the malaria sector. So you have the campaign for the onco that is already, talks already been done on how we can digitize some of this program implementation. Also in Nigeria, there's also a plan now that is ongoing to use the ICT4D for SMC campaign in Kano State in Nigeria, but there's going to be a pilot campaign.
Was that a call for the next slide? Sorry, we lost you again.
Yes.
Oh, no, we got you back. Okay.
Okay.
Thank you.
So looking at an experience from Sierra Leone, we can see that CRS helped implement the 2013 MIS using iPhone Builder and leverage on data collected to create the IRS intervention and malaria prevalence map using GIS. So basically what CRS did was in 2020 was to use the iPhone Builder to support the country. And they also used this platform as well for the 2016 and 2020 MIS. They used the templates to support the country to collect some of this data. So CRS as well, team also helped Sierra Leone with a mapping exercise for IRS intervention as well as malaria prevalence. So if you look at the graph towards the right, you can see the prevalence of malaria across the regions of Sierra Leone. And on the left side just shows the health facilities. And looking at the right side, you can see the density of the homes spread around the homes around some of these health facilities as well. So this color coded map shows a visual representation of the coverage in the country. So also in 2020, Comcare platform was used as well to register TBS and SBC volunteers across 16 districts in Sierra Leone, and data from the field was collected and uploaded on the ICT4D platform. So what we can see clearly is that we have a lot of data. The ICT4D platform on the Red Rose can really store a lot of data that can be leveraged on for other interventions to provide the information that can be used. So that's why we don't have to keep collecting new data for different activities. Next slide, please. So also in the Gambia as well, CRS helped implement ITS mass campaigns back in 2014, also using the iPhone Builder is a data tool that collects information as well. And it was a countrywide campaign that registered all households. So most notable was that the data was provided to the government to update their census information as well. So you can see that when we implement mass campaigns, we tend to reach more people. We tend to have a very large coverage and we get a lot of information. So this, what happened was there were some populations that were previously unknown to the Gambia government, but during the implementation of these activities, we were able to identify some of these populations, and this information was provided to the government of Gambia. Then also in the following year, 2015, CRS assisted the country in digitizing of the SMC campaigns as well. So just to say that some of the values and lessons that we've learned actually with the use of technology, you can see that all extensive data collection and collection processes no longer exist when you use paper tools. You have to transmit data from one paper tool to another paper tool. So all those processes have actually been cut short. And there are times that you normally have data computation errors. So most of these have been eliminated with the use of technology. And we now have improved completeness of process, and have timeliness and quality of data. And also with the use of technology, there's been the minimization of ITN loss across mass campaigns, like previously when you could not actually track where these ITNs were placed. But now technology has helped to minimize ITN loss. And also for technology, you can easily identify challenges because the data that come in are actually real time. So you can easily identify challenges and take corrective measures. And this ultimately has helped in improving the quality of implementation of activities across board. And there's also the financial gain as well, following the reduction of paper-based tools. Previously you need to print a lot of data collection tools for like paper-based collection tools. But now with the use of technology, all those processes have been eliminated. So there's the financial benefits to it as well. So if you look at also this map from Gambia, you can see that the blue dots actually show some of the distribution points. So CRS actually led the bednet distribution by districts, and the blue dots, I don't know if it's very visible, shows where we actually had distribution points across some of the regions in Gambia. So technology has allowed us to also save a lot of data for long-term use, which could have been easily lost using paper tools. So if, for instance, we had like a lot of papers that we used to document data as well, there are instances that some of these data get lost, but with the use of technology and hosting some of these data on platforms as well, we can easily have access to this data. Data is not lost, which can be used for other program implementation. So just to say that CRS continues to support malaria control programs and malaria elimination programs for various countries to digitize campaigns using various platforms, ComCare, and we're currently supporting a pilot using the HIS2 tracker as well. Next slide, please. So thank you very much for listening. Over.
Thank you very much, Arezi, for providing this great overview of different tools used and also those different data visualization. I found that very interesting to see in various different countries. So our next speaker is Marie Rain Rutag Vera. She's based in Zambia, working for PATH, and will share with us some lessons learned on combining malaria and COVID response. So Marie Rain, over to you. You might need to unmute yourself.
Thank you, Sonia, in the time of COVID. Next slide, please. Next slide. So as we may all know, malaria symptoms and those of COVID-19 are similar, and if one is overlooked, we may end up having more cases for the one that is being overlooked, and this has an effect on the progress that is made so far. Like for malaria, we've made a huge progress in the fight against it in the past 2 decades. And with the COVID coming in starting last year, was the major threat on the gains that we have made so far, and not just on malaria, but also on other infectious diseases. Therefore, there is a need to sustain malaria interventions, at the same time prevent further spread of the COVID-19. Below some of the lessons that we've learned in Zambia that I'll be able to share with you. Next slide. Okay, so I will be able to share our lessons that are mainly around the how system integral to malaria control and elimination are also key to. We have grouped this into three systems. We need to ensure that there is consistent and steady supply of the commodities, because as the commodities run out, there are chances that we may have an increased cases of getting the COVID-19. We should ensure that we put systems in place that will leave the supply chain open to other systems as well, so that we don't just attend to one health systems, forgetting the other. Then there's also the community-led on system. We have also community health workers, where we take services closer to the people. With that, we are cutting down the travel time to treatment seeking, and also reducing the number of people in the health facilities, the COVID-19. There's also the issue of communication. We need to make sure that we give people enough information to understand how they can prevent both malaria and COVID at the same time. On the collaborative systems, we've noted that COVID-19, as well as malaria, needs an interdisciplinary effort. It's multi-sectoral, and different people, different organizations have to come together to work together to be able to curb both diseases. Therefore, there is a need for us to strengthen and leverage the systems that are in place to be able to curb some of the other diseases like the COVID-19. Next slide. So there is a need that we should continue to provide malaria services if we are to keep the gains and eliminate malaria in the countries that we are working. And some of the ways that this can be done is through ensuring that community health workers that have been put in points closer to the people, especially in rural areas, they are given protective equipment, they are trained, and they're also provided with malaria commodities and guidance on how to safely deliver the malaria services, at the same time mitigating the spread of COVID-19. The social behavior and change communication, we are using that as a means to encourage care seeking, whether it is malaria or the COVID-19. So here we are using the mass media, using radio stations, TV stations, as well as some form of door-to-door, where I use the megaphones, especially in rural areas, giving information both on the malaria as well as the COVID-19. We have also adapted our trainings for integrated community case management to ensure that we don't relax in that area. For example, in Zambia, we still have areas that are not served by the community health workers. So we have adapted our trainings to ensure that while we are training the community health workers, we also mitigate the spread of COVID-19, as well as give them information to go back to their homes and sensitize the neighbors, especially in the rural areas. Next slide. We are also looking at the data. I'm sure we all know that without data, we will not be able to make sound decision, both on the malaria side as well as the COVID side. So as PATH, we've contributed to global guidance on monitoring the routine health indicators to help us understand the malaria surveillance systems, how these are being affected by the COVID-19, also how some of the non-malaria fevers may be attributed to the COVID-19. I think when I started, I did mention that some of the symptoms for malaria are the same as the ones for COVID, and one of these are fevers. have also contributed to the data visualization at the National Emergency Operations Centers and the National Malaria Control Programs to support and coordinate the efficient response. So on the right, we have some of the examples of the dashboards that we are able to develop that help to be able to visualize malaria-related data in the time of COVID pandemic. Next slide. So the other contribution that PATH has had is to leverage some of the existing systems to support and track the COVID-19 genomes. So in Zambia, we have used the genomic sequencing technology that we previously used for antimalarial drug resistance. We use this to track COVID-19 spread, and towards the end of last year, the same sequencing was used to identify a new variant that originated, identify that new variant and able to communicate to the Public Health Institute and notify the Ministry of Health that the new variant had reached Zambia, to help them plan on how to communicate to the people and make sure that the new variant is kept to avoid further spread of the COVID-19. So with PATH, PATH is working with the Zambian Health Institute, the University of Zambia, and the School of Veterinary Medicine to ensure that we continuously leverage on the existing malaria systems and make sure that the new variants of the COVID-19 are tracked and reported on time. Zambia is also building its own in-house genetic capabilities to help us perform sequencing so that we can own the data and drive subsequent research and provide guidance to the Ministry of Health. Next slide, please. Okay. Thank you for your attention. I'll wait for the questions if there are any. Thank you.
Thank you, Marie-Rain, for your insights from Zambia, and also interesting to see how PATH has been able to leverage the malaria systems to support the COVID response. Thank you for sharing this. And our next and final speaker for the presentations is Luigi Nunez. He's the Digital Health and Monitoring Advisor for Malaria and WASH for Population Services International. So Luigi, I know you will be sharing with us some insights on measuring the quality of malaria interventions. Thank you.
Thank you so much. And yes, hello to be here with everyone. Yes, and so as we've seen in the previous two presentations, the digital tools are being used more and more to improve the collection of data and to improve the analysis of data during campaigns, during different interventions. Something that we've been really looking into and focusing on has been the not only quantifying gaps in the intervention itself, thinking about the proportion of people with access to an ITN. We're also looking to measure the quality of those interventions. There was a great presentation on the learnings of the COVID-19 pandemic. And something that we've learned is, especially with these unexpected disruptions, it becomes extremely critical and crucial even to assess the quality of these interventions to ensure that implementation is taking place as expected. What you see on the slide now is one example of how we've been doing this. We've been assessing and monitoring the quality of the continuous distribution of ITNs. Using the digitized Android capture app, we've been supporting NMCPs and district teams to continuously assess the quality of these channels. Our experience has been mostly with facilities and schools, as well as with mass campaigns. Supervision is not necessarily new. Many NMCPs and programs have been conducting this, but quantifying the gaps has been an identified gap. Many gaps have been anecdotally raised, but truly knowing what issues exist in current interventions has been poorly documented. In this example that you see on the screen, we were able to assess a small number of schools as part of a test pilot in one country, and we're able to immediately in real time quantify what's been working well in that school-based distribution and what needed to be improved. In that same country, after that testing, we're able to use that same tool, same app, using a different checklist for over 900 visits to facilities. Normally access to this data, and typically it was more qualitative, was at least 2 weeks, and we were getting it in real time. When we asked, when we tried to look at what gaps were high priority based on quantified results, we weren't able to do that before. From the supervision visits for these over 900 to health facility, we found that 94% of schools, that 94% of the visits to facilities found an ITN inventory control card, to measure stock, but the card was only correctly filled in about 63% of visits. Half of those visits observed an acceptable variance, about plus or minus 5%, between card values and the physical stock. We also found that 85% of the visits, they had sufficient physical stock at the facility, but appropriate storing was only found at 65. So all of these nuances are more about the quality of the channel, how effective can it really ultimately perform, that we were not able to quantify before. And this enabled district officers to act more rapidly. They were able to resubmit reports, resend out ITNs to the appropriate places as needed. We're also using this data to focus on a training curricula to think about what needs to be revised and focused on in future trainings and quality improvement. Next slide. We've also been doing this for malaria service delivery. For many years, PSI has been using a digitized based app called HNQIS, the Health Network Quality Improvement System, and have supported national and district malaria staff to assess, but quickly identify, even at the point of the supervisor, gaps in the services, and then to intervene appropriately based on the identified gaps. What you see on the screen, for example, is assessing performance of clinical visits at outpatient, the readiness of the facility for malaria services, assessing visits at inpatients, at antenatal care visits, and even digging down deeper at ANC around the prevention and treatment of malaria in pregnancy. Again, this is not about the testing rate or treatment rate. This is not about the provision of IPTP. This is really about how are the quality of these services going, and then to be able to dig deeper there. The great example, one great example on the screen is on the top right corner. We had significant differences across regions in one country, where other graphs there was differences, but we could see that there were issues or strengths across the board. But for inpatient care, and specifically assessing the management of severe malaria, drastically differed across regions. And so this has enabled district teams to really think about, and regions, to think about where does training need to happen? What might be underlying causes to poor management of severe malaria, beyond our basic routine treatment and diagnostic indicators. So final slide, please. And so what have we been learning? I categorize this into three main messages. First, it's so important to assess the quality of our interventions. It's great if we can get nets out there, ensure that every person with the fever is getting tested, that every person with a confirmed case is getting the treatment that they need. That's critical. At the same time, we need to be ensuring that the quality of our interventions is being done well. What might patients be missing? What might the communities and households be missing in terms of messaging, SBC, ITN use, if we're not assessing the quality of our campaigns, of our channels, of our services. Also, it's not enough to just get data, but responding and telling how we adapt based on the data. I think the other presentations did a great job to show that as well. The second lesson is leveraging existing tools and ready to deploy tools. More and more partners and global institutions and programs are sharing their tools. They're making it available for others to use, to adapt. A lot of times these tools come already packaged using learnings, so that we can avoid facing those issues ourselves. I think it's so common for us to face issues that other people have faced as well. And just to specifically talk about DHIs too, many tools are coming out for this. The WHO, for example, is coming out with more and more DHIs packages for programs to use and adapt. And then the final message is to publicize. Publicize your tools that you've picked up from other partners and implementers. Put them on GitHub, put them on your website, so others can download, adapt, and use them for their own good. We promote open source tools so that others can take it, adapt it if needed, or just use it as is. And that's it from my side. Thank you so much.
Thank you very much, Luigi. And thank you to all the speakers for sharing the insights. I know we've seen sort of three very different approaches, and seen a selection of different tools being used. So this is also a reminder for all attendees. If you have any questions, either specifically to one of the speakers, please place that in the chat. Or if you have any questions broader to this topic, you're welcome to do that too. But to kick us off, I know we don't have a lot of time for discussion, but I would like to maybe get through a couple of questions. So to kick us off, I would like to talk a little bit about the impact of COVID on the malaria response. I know Marie-Raine, you already shared some insights, particularly how the malaria systems are helping the COVID response. I guess this is sort of maybe a bit more the reverse idea. And I know obviously there has been a lot of impact with remote programming and training and obviously data collection and so on. Just wanted to really see if there's anything specifically you're doing now in your programs that you have not done a year ago, but something that you think you will continue in the future, looking beyond the pandemic. So whether it is to do more digital training or more social behavior change communications, cross-sector or cross-border coordinations of malaria responses or anything else. So very broad question, but I hope you're willing to share some insights. So maybe, Orezi, could I ask you first if you have noticed something that you think has maybe been a positive impact of the more digitization through the pandemic?
Thank you very much.
So, sorry, we have some problems. Sorry, we have some problems hearing you. Can you try? Sorry, your connection is not very good. It sounds very robotic, and I find it very difficult to hear you. Maybe we can try again in a moment. Can I maybe pass on the question to Marie-Rain while we maybe figure out a better connection? I hope we're luckier in a moment.
Thank you, Sonia. I think I'll start by mentioning how the great effect we had on the COVID with the malaria services. Like I mentioned, the malaria services in Zambia are at 2 points. There's a facility level and community level. And one of the challenge we had was disruption in the malaria commodities, where I think at some point we stocked out on RDTs and antimalarials. I think one may wonder why antimalarials stocked out, but because we didn't have RDTs to confirm the cases, most facilities resorted to treating clinically. So that made us consume more antimalarials than we had thought of. So what have we learned from that? I think what we're discussing, I think even this morning we had a meeting with the other teams at the National Malaria Elimination Program. We are looking at the possibility of going forward to increase the lead time and as well as increase the buffer stock, so that in an event that there's a disruption in the supply system, then we should still have kind of enough to go by until the supply until we are restocked. So before we're talking of 6 months, but today we are thinking that probably we should increase to 1 year. In terms of other things that we would like to do is to increase on the SPC side, the sensitization.
Oh, Marie-Rain, we lost you, sorry. Oh, we're not lucky today with the connectivity. That was going very well during the test sessions. Luigi, can I just ask you the same question, and then we also promote another a speaker with maybe better connectivity?
Sure thing. Yeah, so we, in terms of things that we're thinking about, in terms of things that we've changed from COVID and what we might continue in the future, I think we've learned as the world has that we can do a lot more from a distance, both globally and even domestically. I think there's a lot more that we think that can be done than we think. Some things that we specifically implemented has been distance learning, thinking about learning through and training of health workers and community health volunteers or workers through WhatsApp, through SMS, things that sounded exciting before but may not have been a priority for programs or donors, and that's been something super exciting to really be able to push the envelope because of the COVID-19 pandemic. Also leveraging digital solutions to adapt activities. I think there's always challenges with funding and prioritization of resources, but with the importance during COVID of minimizing touch points, digital tools became a critical opportunity to mitigate that. And the final thing I would say is virtual and online trainings. Kind of touched on this before, but even thinking about it from a continuous point of view with colleagues, with partners that you're working with on a day-to-day, being able to provide these webinars, be able to provide short 1-hour weekly sessions to build the capacity between all of us has been something exciting to do more of, and will continue doing.
Thank you, Luigi. And from the CRS side, I would like to ask Ghislaine, could you please step in and share what CRS has sort of experienced over the last year and will continue post-pandemic?
Yeah, thank you very much. I'll step in for Orezi. Yeah, I think CRS have really good experience on this. Remember when the pandemic started, we were full in implementing ATM distribution in Benin. And for all our CPs, what we did, we come up with the contingency plan that all the country developed and for the pandemic. And during the distributions, we make sure that we abide by all the safety guidance, that safety protocol that were out there at that point, making sure that the distanciation that they use all the sanitations in place. And we really leverage on the virtual training, as Nures was saying, make sure that all the training were done in a virtual space. And also the training that we were required to be in person, make sure that there is the few people that were present during those trainings, and cut down the class size for more than half, based on also in guidance in the country itself. And also when we move out on the field, also we leverage an SMS communication to get the word out and how field agents should really comport themselves vis-a-vis of the pandemic, and how they should approach and how they should distribute the commodities. And we come up with a touchless protocol where they have to hand over the commodity, not specifically being in contact with the recipients. Yeah, we, based on the country, we come up with a range of activities, and that help us mitigate. Going forward, we seeing everywhere you can see we'll be leveraging on what we did before, but also coming up with new strategies as we seeing the COVID fatigue settling in different countries. And SBC's activity are really ongoing right now, and at the country level, and try to engage more in the community on the COVID. And yes, I think I'll stop here before not taking too much time. If you have questions, I can go deep into the details. I don't know if Rosie online now, she can add more in Nigeria experience.
Thank you. Thank you very much for sharing this. So my final question is also, I guess, kind of like linked to this. So for your specific innovation you shared, so maybe if I may start with Marie-Raine, some of the work you have shared, what do you see as sort of the next steps? What are you what is sort of next on your list? It's either as a trend or as a scaling up, or?
Thank you, Sonia. Apologies, my network cut. So I think our next step, which is on our P1 is to develop a system that is going to help in tracking the commodities up to community level. As at now, the Zambian Ministry of Health is only able to track up to facility level. So we are hoping to help them develop a tool that can help them do real-time tracking of what is available at the community as well. And then also be able to develop more visuals to help track malaria cases and how probably these could be linked to the COVID cases that we are seeing.
Thank you, Marie-Lorraine. And Luigi, sort of same question for you. You've already mentioned an increase in obviously online training, but for this specifically for the monitoring or measuring program, what are sort of the next steps or the next objectives for you or your team?
Yeah, thank you for the question. I think it's thinking about the future and in general, like just trends in digital and monitoring. I think there's a lot coming forward. Something that we've been doing a lot is this packaging of learnings of tools and sharing them beyond just PSI. Things that we've been supporting have been open source code and tools, for example, on GitHub. A recent work has been a collaboration with the WHO on a digitized package for summary forms, which is common these days, but also for a digital register. So doing that household tracking between registration and distribution. So that programs can use it, edit it, and then change it as needed. But that heavy lift is done. So one thing that we're seeing future trends, and we're doing a lot into the next steps, is that open source packaging of tools. We're also looking at the moving away from many tools to thinking about either one tool that provides different solutions for the health system and or interoperability between tools. The final thing that we're looking at is around AI and the use of machine learning to better predict stockouts, epidemics, and other necessary needs by programs.
Thank you, Luigi. And that's, yeah, a lot to look forward to. And we are already at the end of our webinar. So thank you so much, Orezi, Marie-Raine, and Luigi, for sharing your insights. And thank you for the audience for joining us, and also for your patience through our connectivity problems. You know, with this ICT4D webinar series, we're always looking to hear directly from the practitioners. And unfortunately, that sometimes means we have to deal with different connectivity situations. So thank you for your patience. And we're looking forward to see you again soon at another ICT4D webinar. Before you leave, please fill out the NetHope feedback form and let us know what you thought about this webinar. Thank you so much.
Thank you again, and especially thank you for your patience with our connectivity issues today. Please do take a moment to complete our webinar satisfaction poll. We appreciate your feedback. Look for that email that will contain a link to this recording for this session and other information from today. And with that, we'll say thank you for attending and have a great rest of your day. Thank you.